just want to thank the hospitality of people from Córdoba. I thought that we from Brazil were good guests until I came here. So I'm going to talk about the management of APS beyond anticoagulation, the non-thrombotic APS. So we know that non-criteria manifestations, actually, they are being revealed, and probably some of them, they will come up to the next classification criteria. We don't know too much about the pathogenesis that is behind these manifestations, but thrombosis. And when we reveal what comes from the task forces for the non-criteria clinical manifestations, the manifestations that have a moderate level of evidence are APS nephropathy, heart valve lesions, and livedo reticularis. And this is the reason why I will go through these three, especially because in Manchester, I've talked about the others. So when we look for the Euro APS manifestations, whatever they have in their cohort of 1,000 patients, we see that valve heart disease is prevalent as 12%, renal manifestations 2.7%. We need to remember that people are not enough biopsied, and livedo reticularis 24%. If we compare this to whatever we have in our APS action group, we kind of find close results, like 21% of livedo, 19% of cardiac valve disease, and a little bit more of APS-associated nephropathy. We need to remember that these people, they have also secondary APS associated. And now I'll go through the manifestations. So livedo. Livedo can be the presenting manifestation of APS in 17 to 40% of cases. And patients with secondary APS, they have more livedos than patients with primary. And we need to try to distinguish between what is a pathological livedo than what is a physiological livedo. So livedo physiological can also be recognized as cutis marmorata, and this is seen in young women and in children. If they get warm, they kind of improve the livedo, and in pathological, we can divide this in reticular and in racemosa. There are some researchers that try to distinguish between pathological and physiological livedos according to how big it is livedo. And I just want to remind everybody that is also livedo associated with drugs, like amantadine, that has a catecholamine-proved arteriovascular spasm. It's very interesting that when we look for how the skin vasculature is, it has this kind of cone shape, and in the tip you have the arterial, and once you have an obstruction over there, you tend to have a predominance of deoxidized blood in the venules that are just on the side, and this is what brings this interesting net vascular pattern. And if it's not broken, we call it livedo reticularis, and if it's broken, it's racemosa. There is also an interaction between the APL and the endothelial cells producing vasoconstrictor factors. And when people looked for the histopathology of livedo, it seems that there are very different phases. So like in the beginning, we tend to have an inflammation with endothelitis. Then this evolves to complete artery occlusion. In the intermediate phase, you have a subendothelial cell proliferation. And in the late phase, you have this fibrotic late stage artery. And if you see there what we have in the graph, there is definitely a decrease in vessel diameter from the first phases of the livedo to the last phases of the livedo. And this gets very interesting. And another thing, does not show thrombosis. These researchers here, they tried to look for the importance of livedo, so they evaluated the presence of abnormal pulse wave velocity, pulse counter analysis, and ankle brachial index in patients with livedo in primary APS, secondary APS, and seronegative APS. And they compared patients with livedo with patients with no livedo. And actually what they found is that they had higher ABPI, higher PCA. This was not statistically different, but the pulse wave velocity was definitely statistically different, and people were not different according to the other traditional risk factors. So they understand that this can be a possible associated with accelerated atherosclerosis, and other research have made this correlation that libido is an independent marker of arterial and venous thrombosis, pregnancy, morbidity. So keep this in mind. This is a very important information. So our group in Brazil, I'm part of APS Action, and actually I did a comparison between patients in Brazil with patients from other countries and inside the APS Action. This is a multinational register, and what we observed is that our patients in South America, they had more libidos than Europeans, what was very odd to us. And this was also confirmed by a French researcher, that he observed that Latin America people, rather than, they have more libido than Europeans. So usually we don't treat libido, but you should recommend the patient to avoid cold exposure. But you should treat libido if there is associated vasculopathy, whatever I showed in the histopathology, and you do conservative measures like limb elevation, compression stocking, weight loss, lipid-lowering therapies, blood pressure control, diabetes management, smoking cessation, avoidance of estrogen pills and hormone replacement therapy, and there is a lot of controversy regarding antiplatelets and vasodilators. So Jason's group did this very interesting study where they looked for single-cell RNA sequencing of APS skin, and they compared actually 4 patients with libido with 4 healthy donors. They looked for cell types and differential gene expression. They also looked for proteins that were used to identify intra and extracellular, intercellular communication. They observed that there were 4 distinct types of cells, and more interesting, they demonstrated a pattern of ligand gene expression that promotes proliferation of neighborhood cells, and this is involved with neo-intimal vasculopathy. Very important and interesting information. Now I'm switching to my second manifestation, so renal involvement. So 9 to 10% of APS patients, primary APS patients, they can have renal manifestations. Lupus anticoagulant usually is more associated with people who have nephropathy. And again, I'm not talking about the thrombotic manifestations, I'm talking about the non-thrombotic manifestations. So I elected renal artery stenosis. What is the clinical side? Very important, renal vascular hypertension. Fibrous intimal hyperplasia together with all the other fibrous chronic manifestations that you have in API and nephropathy. And usually these people, they have mild proteinuria and renal failure. And the last square is actually very important. Other associated non-thrombotic renal disease, membranous nephropathy, minimal change disease, C3 mesangial deposits, post-immune, and focal and segmental glomerulosclerosis, they can coincide with APS. I'll show later. When you think about APS nephropathy, you should exclude malignant hypertension, diabetes mellitus, TTP, systemic sclerosis, cyclosporin, HIV, hemolytic anemia, and preeclampsia, because they can have a similar pattern. So APS nephropathy is this thrombotic microangiopathy together with chronic vascular changes. And again, I'm not talking about the thrombotic manifestations, I'll talk about the vasculopathy. And there isn't a way that you can distinguish between these lesions and the typical nephrological sclerosis that is associated with aging and hypertension. So usually in our disease, we have an arterial intima that tends to be cellular and tends to have less arterial medial fibrosis. And usually we also have thrombotic microangiopathy. So again, talking about, it seems that in APS, we have 2 different mechanisms. We have the thrombotic mechanisms and we have the vasculopathic mechanism. And I'm talking about the vasculopathic mechanism. And it seems that you have the mTORC pathway activated, and once you block the mTORC pathway with drugs like sirolimus, you tend to have less cell growth, less cell proliferation, and less cell survival. And this has been described in this very elegant study from New England Journal of Medicine, where they observed in vitro studies that patients who were APL positive and who suffered renal transplant due to APS disease, those that had APL and didn't take sirolimus, actually they had more positive phosphorylations of the proteins of the pathway that I just described. And this is totally connected with fibrous intimal hyperplasia. Well, it's not pointing, so I'll try. With fibrous intimal hyperplasia and in the presence of APL and no sirolimus. And again, once the patient has this fibrous intimal hyperplasia, they tend to have a lower glomerular filtration rate and a smaller graft survival. And this is the study of the last square that I said in that slide. So this is a French study where they studied 29 consecutive renal biopsies. This was examined in 2 French university hospitals between 1980 and 2002. 20 of them had the APS nephropathy, but 9 of them, they had the manifestations that I have said, like membranous nephropathy, mesangial disease, focal glomerulosclerosis, and important, DNA negative, and they didn't have lupus, and they had a longer follow-up, so definitely that was not lupus. So if you have a patient with hypertension and with livido reticularis, you should think about renal disease. You should evaluate urea, creatinine, quantification of urine protein excretion, and search for an active urine sediment. Search for the biomarkers that we look for lupus. Do imaging studies to exclude thrombotic disease, US with Doppler, angio-TCs, MR, angiographies, and if the patient does have proteinuria, hematuria, renal insufficient, please do a renal biopsy. So this is a very interesting French study where they evaluated the safety and effectiveness of transjugular renal biopsy compared with transcutaneous renal biopsy. So all patients that were under aspirin or under anticoagulation, they went through the transjugular renal biopsy, and the rates of complication were really low. Of course, here they were in very experienced and trained hands. And another very good statement from this study is that the biopsy was good for diagnosis. They had enough material. But we definitely need prospective studies, but there are many centers that they are already only doing transjugular biopsies for these patients. So how do you treat them? How do you treat APS nephropathy? General measures plus inhibitors of the angiotensin system. Be careful if the patient does have creatinine higher than 2. We know about the use of statins, but we don't have too much data for patients who do not have dyslipidemia. We tend to give aspirin if these patients are only APL positive, and there are evidence that patients who have renal artery stenosis, they improve with anticoagulation. So hydroxychloroquine is given for patients with glomerular disease and for people who also have high thrombotic recurrence. And immunosuppressants, usually we tend to give the same that we treat lupus nephritis. So my last manifestation are the cardiac manifestations of APS. We know that the heart valve disease, this can range from 10 to 60%. Usually these people, they don't have a high morbidity, and 30% of these people, they can have heart valve disease when they are evaluated by transthoracic echocardiography. Usually you have more mitral than aortic. Secondary APS, they have more lesions than primary APS, and lupus patients who are APL positive, they tend to have also more heart valve disease. So in primary APS, this is a left side valve disease. You can have 40 to 60% of focal or diffuse leaflet thickening. There are some studies that correlated the thickness with the level of the ACL antibodies, especially if diagnostic, like higher than 40. 10 to 40%, they can have vegetation, but few of these patients, see 3%, can have valvular stenosis or regurgitation. And for secondary APS, these people, they tend to have a lot of heart valve disease also. Chordal involvement is rare. This is different than Liebman-Sachs. And it's very interesting, and I consider very cute, this image where they describe it as the Kissen mitral lesion in primary APS. So in systole, usually you have the encounter of the two leaflets, and you have this image that they describe as Kissen mitral lesion. So the pathogenesis of this is uncertain. It seems the people who studied this, they observed that there is APL and complement components on the deformed heart valves. The pathogenesis of Liebman-Sachs is believed to be secondary to the position of fibrin plate thrombi on the affected valve. And the frequency, of course, is different if you compare, if you do transesophageal and transthoracic. So transesophageal is much more sensitive. And for inexperienced hands, they really can distinguish according to whatever they find in echoes, if the lesion is from APS, rheumatic fever, or infective endocarditis. So in APS, you have this diffuse valve thickening. It involves the leaflet's mid portion or base. And usually you don't have calcification. In rheumatic fever, it's the opposite. So the compromise is in the tip of the valves, and you have a lot of calcification. And in infective endocarditis, you have this mobile mass, okay? So the treatment, we do not have a good literature for this. There are anecdotal reports, several small series, but it seems that these people may not respond or even progress despite therapy. Surgical intervention is rarely required, and the new technique of transcatheter aortic valve implantation is what they are recommending now. I almost missed this meeting because my mom had to do a TAVI in 2 days before I came here. So the general measures for people who are asymptomatic, we tend to give them low-dose aspirin. For people who are symptomatic, we tend to anticoagulate them. We don't have good evidence for this. And for people who have APS, SLE, heart valve disease, we give steroids, we give many things, but I'm not sure if we exactly know what is the effect of this. It doesn't seem to be effective for valve healing. So my last 2 slides. This French study just compared people who have non-criteria manifestations with people who do not have non-criteria manifestations. They observed that people who have non-criteria manifestations, they had more preeclampsia, more arterial events, more thrombosis. They were more triple positive, but there was no difference according to survival probability. Maybe because these people were not enough followed. And I'm very proud to show the work, one of the work from my friend Massimo when he spent some time with me in São Paulo. So what have we done? We compared patients with primary APS with criteria manifestations and patients with no criteria manifestations. And we actually observed that people with non-criteria manifestations, they had higher A gaps. So I want to thank everybody for listening. This are the bunch of young people that I'm trying to incentivize to study APS back in Brazil, some of my PhD students, graduate students, and thanks everybody for listening.